This is Ray Hoffman. Rumors of the decline or the demise of the American health system are greatly exaggerated. And in Michael Dowling, the American health system has a terrific advocate. He's the CEO of the largest health organization in New York State, Northwell, largest healthcare provider. Michael Dowling.
Wonderful to have you here. Thank you so much.
I'm so happy to be here. I'm going to start the same place you start in your new book, Healthcare Reboot, with the articles, the various multinational surveys, and at least one bestseller book which you know about, all of which suggest the healthcare system is in decline. There's a lot of noise out there, information out there.
Well, I disagree. I think that they take a very narrow perspective. And I also think that, negativity sells. Pessimism sells faster than optimism.
Always.
It travels faster. If people say something bad about somebody, it just goes around the place like wildfire. You say something positive, you maybe one or two other people hear. So I think that if you want to sell something these days, especially in the current political environment that we're in, you just be negative and everybody picks it up. But there is another side to the story. And that is a story, in my view, of one of extraordinary success. Now, it does not mean, and I am not suggesting for a moment, that healthcare does not have its faults, or that it's not somewhat uncoordinated sometimes too costly, is somewhat fragmented. But then again, there is no organization that you can think of on the face of the earth that is actually perfect in every dimension. So all organizations have faults, and healthcare has its faults. But if you get beyond that and you look at the success of healthcare over the last 4, 5, 6 decades, it's an extraordinary story. Today is a better time to be alive than ever before in history. Today is a better time to get great healthcare than ever before in history. We're suffering in many ways, I would argue, from a crisis of success. And I can elaborate on that later. But to me, it's a time for optimism. Also, there's another reason. Optimism, if you're a leader in any organization, optimism is what inspires. Optimism is what enhances morale, productivity. It's good for your mental health. So how you perceive things and how you look at things and how you communicate about things is important. And you can still be an optimist and have criticisms about those things that need to make it better. But starting from the premise, the negative view and the pessimistic view, I think, is a faulty perspective by many of the people who like to write books and who pontificate, or if you're on the political, election process right now, everybody's out there talking about how bad everything is. Not everything is as bad as they say at all.
Now, just to be the devil's advocate on this, in any story, there's always a grain of truth in the criticism. Where is the largest grain and the grain that bothers you the most?
Well, the piece that I think that we have that bothers me the most and we should fix is that not everybody in the United States has insurance coverage. And I think that should be a major focus of the efforts around reform. You fix that which is broken, but you don't need to tear the whole thing down and start from scratch, because not everything is broken. It needs a rehab job, not a demolition job. And so a lot of the people out here who are currently talking about healthcare and healthcare reform, they want to kind of throw everything away that we've got. And I think those people who have that perspective don't understand healthcare, don't understand how the business works, don't understand the history, have never read about the successes. They're playing to a crowd. And to me, leadership is about having a realistic yet optimistic view of the world. There is strengths, very great strengths that we have in healthcare, wonderful successes, and we build upon that. There's one other thing. We have in our organization 68,000 employees. These are employees right now, as we sit here and speak, are out performing enormous surgery, performing miracles in many ways, keeping people alive, helping people get better. Thousands of people are going to walk out of our facilities tonight better than they came in this morning. These people need to understand that what they do is good. It's not all bad. It's very hard to mobilize a community of people around doing good if you're all always talking about that which is only bad. So from a leadership point of view, I think optimism is a central, coherent, and key ingredient of leadership.
I wouldn't have assumed that optimism was such a center of your leadership definition, but now I'm convinced it is.
Hey, I'm an optimist who likes to disrupt and innovate. Because you've always got to be moving the ball downfield. You've always got to be improving. You've got to be pushing yourself to do better today than you did yesterday and better tomorrow than you did today. But it comes from the premise and from a concept around optimism, a perspective about optimism. You have to be optimistic about the future if you want to do good things. And I'm an optimist and I'm a realist. I've been in the business a long time. I've been in the health insurance side of it. I have been in the academic side. I've been in the government side, so I have seen all the warts. I've seen all the imperfections. But when I put it all together, that which is good dramatically surpasses that which is bad. We fix the bad, we keep the good, and we keep moving forward.
And your background as a teenager working in steel mills in London and working on the docks in New York, how does that contribute to that optimism sense?
Well, I was very optimistic that that's not what I would be doing long term. I working on the boats in the west side of Manhattan. I worked as a plumber. I worked in construction. That I did because I had to do it. But I went to work every day with an optimistic view that I could do the job as good as anybody else. But I also knew that that's not where I was going to spend my full career. I was optimistic about the potential that I had to do other things and more things in the future. That doesn't come from a perspective of pessimism, where I say, oh my God, things are so bad, I'm just going to sit here and do this forever because there's no hope. There's always hope. And I communicate that to staff all the time, including all the staff that we hire. I meet every new employee that is hired.
You still do?
I still do it every Monday morning. And I tell them that every one of you should be in a better place 5 years from now than you are today. And all of you have the potential to get there. Don't ever hold back, and don't ever basically say you can't do something, and don't ever let your current circumstance limit what your future potential is.
Yeah, and I can see how in building a culture, if you can infuse that sense of optimism down the line.
Oh, sure. It enhances the morale of the organization. It's about culture building, etc. And that's the reason, that I, along with Charlie Kenny, wrote the book, was to kind of give another perspective. And I think it's an important perspective, especially in the current environment that we're in.
And there is a subtitle to Healthcare Reboot, Megatrends, Energizing American Medicine. And I assume you would contend that too many people are looking at too many microtrends and not the megatrends.
You've got to look at the world from the balcony. I use this analogy a lot. It's like, I'm a hockey fan, right? And if you're a hockey fan, and I played sports myself back in Ireland, and let's just say, go back to the hockey idea. If you are down near the ice, you see the particular things that go on just right in front of you. Right. If you go up on the balcony, you see the plays develop. So you got to stand back from an issue so you can see the broader picture, and you can see the broader trends. You can see the plays that are being made, or about to be made. In other words, you can see where the puck is going, so that you can anticipate that you're there before it arrives. It's the same with any issue. So I just gave a talk to presentation to our staff here, and I will be doing it again in the next couple of days. And the title of it is A View from the Balcony. What are the big trends? The day-to-day detail stuff you've got to deal with, but it's all inside the context of the larger trends. You've got to understand the larger trends to understand the micro. This is why, for example, I meet with all new employees, because in a typical organization, when employees come into the organization, they come into a unit or a division or a department. And in those units and divisions or departments, and healthcare is no different than any other business here, they'll be working with 20, 30 people. And they'll know that unit and department very, very well. They'll know everything about it. But for the most part, they don't understand how that department sits within the context of the total mosaic of the whole organization. And they sometimes don't see the relevance of this unit to this. So one of the reasons I do the orientation for all new employees is to make that connection. This is what the big picture is. This is your piece. This is what we do here relates to you down here, and what you do down here relates to us up there. So it's that connectedness that is important.
And that's driving results. Obviously, a very important statistic that you mentioned, how in a 5-year period, 2010 to 2015, the incidence of patient harm in hospitals, infections and falls and traumas fell by 21% nationwide, 125,000 fewer patients dying in hospitals, and about $28 billion in cost savings.
And that's just one. I mean, if you look at, take any of the areas that people are mostly concerned about, take heart disease. Just think about having a heart problem in the 1970s vis-a-vis today. There has been, you know, heart deaths from the 1950s to today have decreased by over 70%. Because back in the 60s and 70s, if you had a heart condition, there was very little treatment. There was very little we could do for you.
Yeah, my dad walked into the hospital just before Christmas, 1969, with a mild heart attack. It was a myocardial infarction, and he was gone by New Year's Day.
Well, the treatment then was go home and rest. There was no treatment, and people forget this. That if you were diagnosed with a had a heart attack in the 1960s, the possibility of death was around 40%. Today it's 6%. So today we can put in a stent. We can change your heart. Now, it costs a little bit more today than it did in the 1960s, because in the 1960s there was nothing we could do. So, I say this is the reason when I said there's the crisis of success, and it's tied to the cost issue. When you can do more, you're going to do more. When you can save more lives, you'll save more lives. Similar thing with cancer. The dramatic survivability of cancer today is extraordinary. I think it's been in the last 30 years, there's been a 25% reduction in mortality, cancer mortality. Take stroke. Take infant infant care. Babies being born a pound or two, 20, 30 years ago. Take musculoskeletal. You had a bad hip in the old days and you like to play golf. It's a matter of, okay, well, suck it up and deal with the bad hip. Today we can replace your hip in 38 minutes. Your shoulder, we want to have a bad shoulder, we can replace it. That's all good stuff. Now, it does not at all take away from the fact that there are things that we all need to improve. Everything needs to be improved. Nothing is perfect, and you never get to the state of perfection. But the trends over time, the way we get paid today is a little bit differently. That's beginning to change dramatically. Everybody today is talking about the fact that if we want to improve health, we got to change the lifestyle, behavior, and social circumstances, social determinants issues, exercise, food intake, obesity. Those are the major determinants of good health overall. Medical intervention is a part of it. That's being discussed by everybody today. In fact, in our organization, we had a 2-hour meeting on this morning. The whole focus on behavioral health, the integration between mental health and physical health is today being discussed by everybody. It wasn't that way 20, 30 years ago. And on and on and on. So these are the big trends.
And each of these trends, and one of the things that I found so interesting in the book, each of these trends feeds into the next mega trend.
Oh, absolutely. They're all interconnected. Yeah. I mean, obviously when you do a book like this, you kind of separate them, but they're all interconnected. And then if you look at the issue of technology, now here's another issue that I take issue with. If you listen to some of the so-called whiz kids out there that pretend to be experts in healthcare but have very little experience, they'll tell you, well, healthcare is way behind in the area of technology, that we have got to come into the modern world of technological know-how. Well, I would argue that that's ridiculous. Healthcare has been at the forefront of technology over the years. Yeah. You go into an operating room today, or go into over the last decade, and look at the technology in an operating room. Look at the technology in an intensive care unit. It's extraordinary. We've been at the center of technological advancement, not behind. Now, where we need to improve is in the direct interface with consumers, telemedicine, digital health, the implantable devices, monitoring devices, etc., which we all do today, and that's growing dramatically. But you know, you have a lot of people out there in the tech world that like to sell you a product, and they set up this whole scenario that, well, we have to sell you a product and technology because obviously you're way behind on technology. And that's the way.
Does anyone in your industry believe that? You talk with other CEOs. Does anyone buy into that?
No. The people selling you the product buy into it because I want to sell you a new product.
Right.
And I'm not suggesting that some of the new products are not good, and I'm suggesting that they're malicious in any way. It's just that you've got to look at it through a broader lens. Healthcare is moving along at a phenomenal pace. Today, for example, the new developments with the mapping of the human genome, immunotherapy, all of the new things that are coming out today. Bioelectronic medicine, which we're the leaders of. The things that are happening today will allow us to do things in the future that we can't even fully today comprehend. We will prolong life more. We will save more lives, right? We will cure things today that we can only imagine, but it is going to take more resources. So we got to take the inefficiency out of the health system, but you know, the bulk of healthcare costs are connected to the, you know, what people spend at the end of life. And that's growing because we're living longer. It's a success. We're so successful at keeping you alive longer that it's now costing us more.
It's the consequence of
It's the consequence of success,
yes.
Not a consequence of failure.
Yeah. Now, a central point to the critics is the way the doctors and hospitals traditionally have been paid, you know, this series of billable events. Sure. But you point out in bold print in one page of the book, when you change the way doctors and hospitals are paid,
you change the products.
Yeah.
Yes, and that's now it's not happening as fast as some people thought it would, including me, and it varies depending on which part of the country you're in. Because if you're in the Minnesota area, they moved it much further quicker over the years because the local cultures were different, etc. So it doesn't move at the same pace across the United States, but it's moving. So all contracts today that we have with all of our payers, and this is a trend across the United States, are all moving towards changing the way we get paid. That's a positive thing. So, you know, some advocates would like it to happen much faster, but cultural change is hard. You just got to be persistent, keep pushing, and you will eventually get there. So we're getting paid today in many ways a lot differently than we got paid years ago. That's a good thing. And that's changing the way we think about everything.
And you talk a lot in the book about value-based pricing. What is value-based pricing?
Well, value-based care, I use the word value. I mean, it's value to me is the outcome, your outcome, its convenience, its access, and its price. So, for example, and this is something that people have to be very careful about. People also think that if everybody has insurance, that they have access. Insurance does not guarantee you access. I mean, you can be insured, and if there's no healthcare around any place where you can reach it, and you don't have transportation, and there's no subway getting you there, and you don't have a car, you have lack of access. So we got to make sure that just because you have insurance coverage doesn't automatically guarantee access. You got to look at both of them a little bit different. Convenience today is a big issue and I put that in the context of value. Patients today, especially younger patients, want things quicker, faster. They want to walk into a place and be treated like VIPs, right? They want parking that's easy. When they walk in, they want to be seen quickly. They want to wait in waiting rooms for hours. That's all convenience. And then there's the issue of price, which is very complicated. So people like say, if you go to the doctor, I want to know what it's going to cost me before I go. In some cases, that's possible. In a lot of cases, it never will be. Because you come into a physician and you have a digestive problem or a heart condition. We don't even know what you've got before you come in. I can't give you a price because I don't know what you've got. And when I assess you, I find out that you have one problem, but then I may find out you have 3 other problems. Very different. If you come into a place, for example, a simple one, and you have a shoulder that needs to be replaced, and you have no other medical problems whatsoever, I can give you an estimate of what the shoulder would cost, assuming there's nothing else wrong with you. But that's not the bulk of patients. So a lot of these people say, well, we should post prices. Well, if you go to, and I say it's like when you go in to buy a car, but when you go to buy a car, you have a good sense of what car you want. When you go to the doctor, you don't know what's really wrong with you, and they don't know what's wrong with you. So how am I going to give you a price when I don't know what it is, the condition, I don't know the condition that you're in? This is a very complicated area. I believe there should be more transparency. I believe that where it is where we can actually give people information about what the cost is out of pocket, we should be doing that, and we have processes in our system to do this, because I think what people are really concerned is about what have they got to pay out of pocket. So there's the cost out of their own pocket, and there's the cost of insurance. So people are very concerned about what they have to pay themselves. What's the cash put out? And I think we can do a lot better job there. But this idea that for every condition, before you come in, I can give you an actual price or an estimated price, I think is just, putting up an expectation that really can't be met. And I think we do a disservice to the discussion to go there.
I mean, it is medicine after all.
Yes.
It's healthcare.
Yes, and much of it is trial and error. You try things, it doesn't work. I mean, I've had numerous surgeries personally, and I have a heart condition. It's in my family. It's genetic. And I had to have back surgery. This is a good example. I had to have back surgery there a couple of years ago. I had 2 back surgeries, which, by the way, I would not recommend to anybody. But when I went in to have the back surgery, the orthopedic guys, they knew exactly what they were going to do. My problem was that the cardiologist had to make sure and the anticoagulation guys had to make sure I stayed alive, that my heart kept working while they were doing my back. So I went in for an orthopedic procedure, but the real problem was watching my heart. Right?
Because of another issue.
Because of another issue.
Yeah.
That's the complexity of this. We want to keep people out of hospitals as much as we possibly can. But for people who should be in the hospital, they should be in the hospital. Hospital is a great place for people who should be there. And we've got to make sure we provide expert care for people who need to be in the hospital. What we try to avoid is not having people in the hospital that shouldn't be there. So in our system, for example, we have 23 hospitals, but I have 720 outpatient ambulatory facilities. Some of them are 500,000 square feet. So over the last decade, we have been moving more and more care out into the community away from hospitals. But hospitals are still important, because as the demographics change, as people age, there's chronic illness because connected to aging, chronic illness increases. Hospital care, hospitals, I hear people saying out there, well, hospitals will disappear. These people are smoking something or dreaming. The people who say hospitals will disappear. Hospitals will not disappear. In fact, in many cases, there will be more need for hospitals given the local demographics. But all the people who are in the hospital should only be the people who need to be there, not otherwise.
And I see you've reduced the ratio of outpatient to inpatient to about 50-50.
We're about 50-50. If you went back 10 years ago, we were, I'd say, 85% hospital and maybe less than 20% outpatient. Today we're 50-50. So we've made a huge transition. That's a major trend. Most cancer is now outpatient. Imaging is outpatient. A lot of surgery. I would say over time, 70-80% of surgery will not need to be done in a hospital. It'll be done on the outside. And when you add to that telemedicine, digital health, all the new technologies where I can monitor you from a distance. You don't have to come in to meet with me. I can monitor you from a distance. You can be at home and I can monitor, so you don't have to come in. That will again change the way we can provide access to care using technology with one caveat. That technology will always be great as long as it doesn't eliminate the need for the human contact. It's the combination of the human contact plus the technology. Technology is a tool, but if you substitute the human element with technology only, I think we lose something special in healthcare.
And the new generation of doctors that is coming along, they're very fluent and very comfortable with technology in a way that the doctors you and I grew up with.
Oh yeah, the new group, I mean, they'll have a problem writing. You know, you'll give them a pencil and they'll say, what is that? Or paper. I mean, I use paper. And that goes back to, like, for example, a lot of discussions that are going on, you know, about the electronic record, you know, where there's, you know, the electronic record had some good things, but it has never met the promise. And it's confusing to a lot of people, it's costly, and it's one of the reasons for physician and nurse burnout and stress. And there's an awful lot of doctors terribly, terribly frustrated by it. It's a constant complaint. The new doctors coming out of medical school, technology, they will design these technologies.
I'm wondering how much time and effort is also spent on the metrics of quality now.
Well, there's an industry, and government is a big problem here. We should measure what's relevant, but not spend our time having hundreds of metrics that requires providers to spend an enormous amount of time documenting stuff that has little relevance to the outcome at the end of the day. I've always advocated that, for example, if the government said we're going to put forward 6 quality metrics, like, for example, I'll give you one. All health systems over the next 5 years should reduce mortality as a result of, reduce the incidence of sepsis, you know, infection. Let's say by 70% over the next 5 years. And we all focused on that. And then we didn't have to spend all of our time filling out volumes and volumes of paper and documents and electronic stuff that nobody ever looks at, and you fill up, but if you don't fill them out, you get dinged. So if we just targeted a couple of things and made progress on it, we would make major strides forward. If you're running hospitals today, you've got hundreds of metrics, hundreds. Staff are, I can't come up with the right phrase. They're metric tired. Nurses spend 50% of their time documenting. And people say, why doesn't the nurse spend more time with the patient? Well, they're documenting stuff all the time. And every time there is a new committee set up by any level of government, whether it be the state or the city or any of these intermediary groups that are set up, where we're monitored by everybody and anybody, somebody always comes out with a report on something. There's an industry that has just sprouted up over the last 10 years. And I'm not so sure it has really made much of an improvement overall in the outcomes that we desire. I mean, every hospital at some point or another in the last 15 years have been designated by somebody as the best hospital in the United States. And that's an impossibility.
Yes, that's right. Now, there's another megatrend we should talk about, and this too is revolutionary, and you discuss it at great length in the book, and that's the crossing of the line or the breaking down of the wall between physical health and mental health.
This is a huge, huge issue that's very important. And again, over the years, you know, you've had, and we're a big provider of mental health services here. We've got psychiatric hospitals, etc. So you've got, you know, governmental departments and hospital departments of mental health. And then you've got physical health. And medical schools, you know, in the training of doctors to do all of the physical health, the stuff that we're typically used to, don't have an awful lot of expertise or have very little training in the mental health side of it. But when a patient comes into a doctor's office, they have both, many of them have a physical health problem, and a mental health problem. And I have doctors talking to me all the time and saying, about 50, and one doctor said to me recently, in my practice right now, close to 20% of the patients that I see have a behavioral health problem. But I am not equipped, and my office is not equipped to deal with the behavioral health problem, so what do I do? So what we're trying to do is integrate behavioral health workers, mental health workers, whether they be social workers and mental health nurses, in with the physician's offices, so that we can take a much more holistic view of the patient and provide a more holistic treatment plan. So that integration is beginning to happen. It's not there yet overall, but it's beginning to happen. And I have observed, because I've been in the business a long time, and when I was in government, I was the head of Health and Human Services of the state of New York. This was a big issue for us. And I've seen a big change over the years where it's getting closer and closer and closer. And physicians, in our system, and I know in others because I've spent time talking to them, I will openly talk to you now about the need to bring behavioral health into their practices.
And that's a change.
And that's a very positive change. I'm not suggesting that we have succeeded yet, but if you look at it from the balcony again, it is a very positive change, and only good things emanate from that. And what we can be doing is, again, from a regulatory point or any other, or from a government point of view, is beginning to separate it and silo these functions again. We can't be doing that. It's all about integrative medicine. All about looking at a holistic picture of the patient, and that incorporates the physical, the mental, the social. And you need to have all of that together. That's where the electronic record, if it's or whatever we call it in the future, has to accommodate that integration. Otherwise, it doesn't work well.
I'm curious about the cultural difference between psychiatrists and medical doctors. And I remember you telling me years ago that when you had to engineer the merger of two rival hospital systems, North Shore and LIJ, that you had any number of people that actively disliked each other that were going to have to work together. They didn't know each other, of course, but they just disliked each other because they were from two different organizations. And you brought them together by having them have a drink with you and just discuss their lives and their families.
Well, you know, I don't want to suggest that alcohol solves all problems. I mean, that's another social issue. Definitely being Irish, I would never want to suggest that. But I'm a big believer, and I still do this every day. I mean, I met with physicians this morning at 6:30. I do it every day. I'm a big believer of getting people together, because when people sit far apart from one another and they don't interact, they believe that the other person has horns, right? Oh, he's a bad guy, but you don't know him. Well, I don't like him. I hear bad things about him. I have found over the years that, you know, and this is human nature. This happens in families, right? I mean, you know, in-laws and mother-in-laws, father-in-laws, brothers and sisters. This happens. But integration is, in my view, is about bringing people together, getting them to know one another, finding those common elements between them, talking about their kids, talking about their grandkids, talking about what they do outside of work. And you find these connectors. And then people say, oh, you know, he's not a bad guy, he's a nice guy, or she's a nice person. I can work with that person. And then you keep working. It takes a lot of time. But we all like to belong to social groups. We're social animals. And part of the danger today is because of all of the electronic equipment we got, all of the iPhones and everything. We're all connecting with one another, but we're socially isolated. So you got to bring people together, personally. Put the phones aside, bring them together, talk about things. This is why, for example, I hold a lot of meetings with physicians and other staff every day away from the office. I meet in diners in the morning. So I get somebody or two people that have an issue. If I meet them in the office, it's a kind of a formal meeting, everybody plays their role. I meet them in a diner. They let their hair down. They relax. They have a cup of coffee. You tell jokes. You kid around, right? And you get serious. But you communicate. Communication. And in many ways, this is how we built the culture here. We're very integrated as a system. We all work together in teams. We're very collaborative, but it's a work in progress. As I said, you never get this completely right. So you've got to work on it all the time. But this is what I love doing. And, you've got to get sometimes down into the details. And if I have a problem with a physician or a staff person, I meet them in person. I don't do emails. I don't send a letter. I want to talk, meet in person. And when you find out, by the way, that when you meet in person, the problem that you thought you had is never as big as what you thought it was, right? And if a person has a big problem tonight at 5 o'clock, what I like to tell them is, well, talk to me about it in the morning. And we've all experienced this. So you go home, you think you have a big problem, you sleep on it, and you get up in the morning, sometimes you can't remember what the hell the problem was from the night before, right? Often. Or you say, Well, yeah, it's an annoyance, but it's not a really big problem. So you give it a little bit of time to flush itself out, and then a lot of problems disappear.
And 5 years from now, is there one aspect of Northwell that will have changed more than any other?
I think the answer to that is to be careful what not to change, number one. Don't change the human aspect of care delivery. Don't change the face-to-face connectivity that's so important to people's health. All the technology and all the things that people bring to the table would like to suggest that we can do more by kind of eliminating that or reducing it. That we just should not change. So it's many ways it's important what you not change is what you do change. So I do think we need to expand the element of technology, but not change the culture that you create. Culture is important. The teamwork, collaboration, integration, that feeling of mission, making sure you take care of everybody irrespective of circumstance. One of the areas that I think that we need to do more in is, and we have had wonderful success. I mean, we created a very unique medical school. Our medical school is phenomenally successful, and we changed, for the most part, we changed the way medical education is done, and we are a national model.
No lectures.
Huh?
No
lectures, etc. And we've had phenomenal success. Our national standings are phenomenal today. We're only existed 10 years. We're now ranked with the top places in the United States after 10 years. But how we educate people in the future, this is with physicians and nurses, but this is just the tip of the spear. But as you look at the world that we're moving into, with all of the new, the new focus on technology and convenience and everything, and the new skills that will need to be available, how we educate all staff in the future will dramatically have to change. We will have to because you can't deliver a totally different product 10 years from now by educating people the way you did 10 years past. So we've got to bring the education, and we're a big educational center here. And a lot of education is going to be happening inside big organizations. You work with the schools, you work with universities, but we are an education institution. How do I educate, and how do we educate all of our staff to be relevant to the needs of the consumer in the year 2035? That's the big question. And we're making lots of plans on that at the moment. Because if I want a different product in the year 2040, I got to figure out how to educate all the staff. It's not just the docs, but the person who cleans the floors, etc. All of the staff to be educated in a different way, and to have a culture of continuous learning, where people are always stretching their imagination, stretching their perspective, learning new things, forgetting old things. Most people learn new things quickly, but they forget the old things. So they block all new things on top of old things. So you got to forget things and learn new things. That to me is a huge challenge for large organizations going forward. And it's not just relevant to healthcare. And this is also one last comment. The formal education systems that we're used to have to dramatically change. They're becoming obsolete. We have to, the high schools, the colleges, all have to be thinking completely differently about how they teach and how they get people to learn.
Do you have a department somewhere here on Long Island that's specializing in cloning executives? Because we could use about 6 of you around in various tasks.
Yeah, but that couldn't get the accent.
Yeah, well, that's special.
That's,
I agree.
Yeah. No, like I love what I do. I mean, I get up every morning. I can't wait to go to work. I work 7 days a week. I enjoy it. It's when people ask me the question, how do you balance work and life? To me, it's the same. There's no difference. If you're not excited, in healthcare especially, because what we do is so important, we should feel so privileged to work in healthcare, because you have the ability to make a change in people's lives more so than almost in any other endeavor. And you're face to face with the customer every day. I mean, I'm out in the facilities a lot. So to be able to get up in the morning and be able to think about how do I do things better so that the tens of thousands of people today who come through have a better experience than they did last week. And how you come up with new treatments and new ways to train staff, how you create an improved culture, right? How you get people to work collaboratively together. This is phenomenal opportunities. But you've got to be excited about it. It's got to inspire you. And I tell staff every Monday morning, you don't have a job here. This is not a job. You have an obligation and a responsibility. It's different. If it's a job, I say to them, go work in a hardware store someplace. Here, you have an obligation. And if you think of it that way and you ask yourself the question, how can I do something better for other people tomorrow? And then go home at night, look in the mirror and be able to say to yourself, I did good stuff today. That's optimism, by the way.
Spoken by a fellow who obviously enjoys having his seats in the balcony.
Yes, because I like to see the place develop.
Mm-hmm. You know, I could continue talking to you for about 4 more hours, and I wrote 10 pages of questions here, and I got to maybe 2.5, 3 pages of them. So I'd love to continue this another time, but in the meantime, this is a wonderful book, Healthcare Reboot. It is thick with, and it's got my marks everywhere. It's thick with innovation and excitement and all sorts of forward-looking possibilities in the healthcare industry, which Northwell Health is certainly a leader in, and you certainly are too, Michael Dowling. So continued success and continued good work.
Thank you so much for giving me the opportunity to speak to you.
Anytime.